Recording in progress.
All right, well, that was a very generous introduction and kind of overwhelming. And Andrew's, I think, very shy today, so he's making me stand up and give this talk. So I just wanted to start by saying the one thing that I've learned so far in my career over 20 years is, if I can give you any advice, is longitudinally follow your patients throughout your career. So make sure that you stay in touch with your patients over time and that you continue to follow the long-term outcomes of the interventions that you do. And you will always be a better surgeon. You will always have more insight. And one of the biggest problems that I've seen is when we become disconnected longitudinally from our patients and we don't understand the longitudinal impact of what we're doing. And a good example of that is when John Hunter's group published that paper on putting mesh in. And the 3-year outcomes looked quite good. The recurrence rate was supposed to be really low. And then people went out on a limb and started gluing these meshes in, and people got really fancy and forgot to follow these patients all the way out. And then finally at 5 years, they started seeing all these horrific complications. And I've been doing complex foregut surgery for 20 years. And the 2 worst complications I've ever seen were with mesh around the esophagus. And if I could go back in my life and redo 2 cases, only 2 cases, it'd be both of those. Both of those people are eating today, but it was not without a similar arduous journey as this. So I think try to make sure that whenever new technology comes out, that you longitudinally follow it throughout time. So I just wanted to start by thanking Dr. Andrade. We've been friends for a really long time, and I don't know if you remember, but I came and gave grand rounds here, like, I think it was 10 years ago around here. You had a foregut conference, a lot of bariatric discussions and really complicated cases that we presented, and we talked a little bit about supercharged jejunums. But we go back 20 years and a lot of history. I'd like to take a minute to thank all of his partners that I got to have dinner with last night. That was a lovely dinner and really enjoyed having you guys come to Houston. I think if you look at a longitudinal career over time, one of the most joyous parts of being a surgeon is building these friendships and these linkages across the country, and then going and seeing people that you've known for a long time leading in their institution, and all of the people that have had such a different life because of their presence. So thank you for that, for being a positive influence on my life. And this is when we were in Brazil together. I dug this up for you last night. So we were in Belo Horizonte, Brazil. And I think this is the one meeting where I've given the most number of talks. I think I gave 12 talks. But it was great. It was a lovely time. And we worked on trying to build a consortium of women who might be interested in cardiothoracic surgery. And we held this little reception in a room that was about as big as this stage. And more women in Brazil showed up. We had to rent like a 10 times bigger room because there wasn't enough room to contain everyone. So it kind of feels like that now. I mean, I think I only see 4 guys on this side. Do you let guys into the program anymore?
Occasionally. Very select.
Maybe the men might be the support groups now. So I'll be talking to you today about complex esophageal reconstruction. and this is something that's near and dear to my heart. When I was training as a resident, I initially started out wanting to be an aortic surgeon. And actually, I wanted to be an artist. And I was so terrible, nobody would buy my paintings. So I went to med school. Then I finally went into cardiothoracic surgery and trained under Joe Caselli and ran his aortic room for 4 months. And quickly realized that I was very interested. I don't know why these are automatically advancing, but I got interested in cancer patients. And when I did my super fellowship at MD Anderson, I learned that doing these complex relationships with patients, these complex reconstructions, was something that to me was very exciting because it was still a part of surgery where you could be creative, where you could draw the anatomy of what's wrong with the patient, and then you could draw what you want to do. And sometimes you got to make things up. You got to recreate a pathway, recreate a new conduit, recreate a way to rebuild a human so that they have a good quality of life. So this is a paper that we just published in the Annals last year, and I'm very proud to say it was one of the most read articles of the Annals of Thoracic Surgery, which is our major journal, highest impact journal for cardiothoracic surgery. And it basically takes you through all the different ways that you can rebuild an esophagus. Some of these, Dr. Huang is the only one that knows how to do it, and I just kind of stand there and watch him do his magic, especially when it's an anterolateral thigh flap or a pedicled myocutaneous flap. But these different types of reconstructions are basically any type of defect can be filled by one of these conduits. So this begins with a stomach conduit, which is the most common type of reconstruction that we use. And I'd say 80% of esophageal reconstructions are done through like an Ivor-Lewis or a transhiatal or a McEwen approach, where we take the gastroepiploic artery as the pedicle and we staple a tubularized stomach and we bring it up and deliver it for either a thoracic anastomosis or a cervical anastomosis. No matter how you connect it, it usually ends up in almost the same spot. But sometimes the stomach isn't pulled up high enough and it's very low. And that results in terrible reflux, which we've learned from following longitudinally our patients. So when we do the thoracic anastomosis, you can use an Orville stapler or an anvil stapler, either coming through the middle of the staple line or with a purse string, or you can bring it off to the side. There are a variety of ways you can do a stapled side-to-side functional end-to-end anastomosis. All of you've probably seen a variety of different ways. I would recommend for the residents, as you're going through your training, try to get your attendings to show you as many different ways to create an anastomosis as possible. You need to learn a hand sewn, a stapled side to side, and a circular stapled, so that when you get in a particular situation, you have a lot of tools in your toolbox. You don't want to just learn one way. When I went through training, a ton of my colleagues went to a particular institution where there was one famous surgeon who did it one way, and they came out and they only knew one way to do everything, and they had very closed-minded thinking. So you want to learn how many tools you can put in your toolbox. So this just shows the anatomy of the esophagus and all the related structures, whether it's the azygous vein, the aortic arch, or the recurrent nerve, or the thyroid. And then based on that location and the cervical spine anatomic landmarks, what different conduit reaches where. So when I was training, this is something that really was confusing to me. I didn't understand how far can you get a roux to reach? Well, you can only get a roux to reach up to about the inferior pulmonary vein. If you're stretching it above that level, you're going to end up with an ischemic tight anastomosis. And then sometimes you can bring your gastric conduit up a little bit higher, and then you can bring a jejunum all the way up to the earlobe if you want. So this just takes you through when to use specific conduits. If you have a necrotic conduit, like the case that we just saw, or an undilatable stricture, or some type of a disaster that happens, sometimes you can save half of the gastric conduit, in which case you can just bring some jejunum up and interpose in between. And in other cases, the whole stomach's necrotic or destroyed or has cancer in it, and you don't have the option to use any of the stomach, and you have to reconstruct completely. So I made this map to help. And I'm happy to share these slides. I think you guys already have them, so I'm happy for you to share them. And then we have the C-word classification, and that's based on the epicenter of your tumor. So if you have an epicenter of your tumor that's at the EG junction, those cancers, if they go up and down, typically are treated like an esophageal cancer. So we nowadays give FLOT with durvalumab before and after surgery. But those patients that have an esophageal primary tumor will require an esophagectomy and just part of the stomach to be removed. But if you have a reasonable amount of the tumor going into the stomach and you're looking at a C-word 3, almost all C-word 3 gastric cancers, they're called EG junction cancers, but they act like gastric cancers. Those need a removal of your stomach. And typically we want to get 5 centimeter margin above and 5 centimeter margin below. If you're trying to bring a root limb up and you can barely get it to go and you can't really get quite a 5 centimeter margin, I think that's okay, so that you don't have to convert the patient to a bigger surgery. But you're always hedging your bets and trying to do the best cancer surgery you can with the best reconstruction that's possible. So what if you're doing your surgery and you damage your gastroepiploic? So you can always use the ICG. Do you guys have ICG here and use that? Have you seen that for esophageal reconstruction? So this is what it looks like. And this is not my best conduit. This was a conduit that I was trying to salvage. It was a patient that had had a complication and we were trying to use the stomach to pull all the way up. But you can see this first half of the conduit has great blood flow and it's pretty much black over here. So I was not excited about using this conduit. Sometimes you can try to warm it up and see if it gets better perfused. You know, you can try all the tricks, spraying it with papaverin, doing whatever hocus pocus you might want to try, but I would never use this for an anastomosis. It's doomed to fail. This is a little trick for those of you who might, if you're just doing like a gastrointestinal stromal cell tumor and you happen to damage your gastroepiploic, it's always possible to do a reversed gastric tube that comes up. I had to dig into the archives of Mayo Clinic illustration to find this because it's so rarely done, but it is an option. And again, having as many tools in your toolbox, understanding when you can use what, is always going to fare better. So this is an option only for like a stricture or a benign EG junction. You aren't really going to get good cancer margins and you're not really going to be able to have a great reconstruction option if you just use this. So a lot of times, some of these cases, like what was presented this morning by Sarah, or other cases will come to me and patients had complex anatomy where they had TE fistula as a baby and you don't have an op note anymore. It's all been destroyed. So we started doing 3D arterial reconstruction with the artery and the vein to try to figure out what options do we have. Is there an intact gastroepiploic artery? Is there an intact jejunal arcade? What are our options? Because a lot of times these people come and there's something wrong with the colon. And if you can't use the colon, definitely you know you're going to do an SPJ reconstruction. Or if you have a problem with the jejunum, like they've had a prior gastric bypass with a Roux-en Y and they destroyed the jejunal arcade, then you might have to use a colon or a supercharged colon. So these reconstructions really help us to start to see where the different details might be to help us guide what type of conduit we want to use. So now we have a free jejunum and stomach. So this is when maybe just the top half of your stomach became necrotic, or maybe the top half of your stomach had cancer in it. So you have you have like an antrum that you can pull up and you want to bridge that gap, and you can do that with small bowel. So alternative conduits, really recurrent tumor. So I have a patient right now that I'm dealing with that I did an esophagectomy for him 15 years ago. And now he has a new cancer in the native esophagus from reflux from the gastric conduit that was connected. He has probably a field defect where he develops cancer, and he's now been surveilled under Barrett's and has a T1B esophageal cancer. You could treat him with endoscopic submucosal dissection, which we did, The margin, the deep margin, was positive. So now he has the choice: definitive chemoradiation or surgery. Most people don't want to have a redo esophagectomy, so we're going to try to do chemoradiation. But he's 80 now. He's not the spring chicken he was when I did his first surgery. So instead of doing flat durvalumab, we'll probably have to do FOLFOX durvalumab and then restage him. And if he's done the whole course and he still has residual cancer, then we might have to do a redo reconstruction. Or you have a case like this. This is a lady that was sent to me with a dead gastric conduit. Or no, this is a dead colon in her position. So she, like that patient that you had a little leiomyoma in her esophagus. A surgeon tried to resect it, left her with a big perforation, tried to deal with the perforation, couldn't get it to close, tried serial problems, finally pulled up colon. It was that surgeon's first colon interposition they had ever done. They basically read the textbook and then tried to figure it out and tried to do it. Colon interposition died, and then that's how I met this lady. So I wrote it. She's in one of the chapters of my book called The Support Group. And this woman came to me. It was actually bleeding, and we had to embolize it because she was so profusely bleeding because it was necrotic. And then after embolization, it was obviously more necrotic, so we had to remove it. So when we have to take any conduit out that's failing, we have to divert. And this is what an esophageal diversion looks like. Sometimes we're able to divert over to the side, but then when we go to reconstruct, you end up with this awful looking T incision where we make an ellipse around the area and you have your incision to do the supercharge, but then you've got this T area that doesn't heal well. So we started thinking, why aren't we smarter about the way that we do the diversion? Why are we doing the diversion in the same place? Because I was taught when I was a resident, always bring it down low on the clavicle and off to the side. But what's wrong with bringing it down in the middle? It actually fits on an ostomy. Wafer pushes up against the sternal bone a lot better because you have a firm, flat surface to fit. And the happier the ostomy, the better the patient, the more they're willing to wait, get good nutrition, optimize before they reconstruct. So in this case, now we bring our ostomy out in the midline, which is good as long as they don't need a tracheostomy. But when that future incision gets made, it's just incorporated into our longitudinal incision and it looks much better. It's more aesthetic and it also heals better. So this is where when a disastrous case happens, the patient is always upset, but you have to remember you have multiple people that you have to take care of. As a surgeon who spent 20 years of my career caring for patients who've had disasters and trying to fix them, you always have to remember, like Dr. Andrade said, the surgeon. The surgeon that created this patient who now doesn't have continuity, who had a gastric conduit that died, needs just as much care sometimes as the patient, because no one does that to a patient on purpose. So I always try to stay in touch and close contact with the surgeon that did their original surgery to try to teach them what I might have done different in a very caring manner, but also to let them know that we're going to take great care of their patient and we're going to try to get them back to where they need to be. So remember that. Don't be critical of the person that sends you their complication, because we want to be able to get these patients as quickly as possible, because the failure to rescue, the diversion of the ostomy, and all the complex surgeries that you're going to be doing to that patient, the more readily that surgeon sends them to you, the quicker you can intervene. And I think that's a critical way to getting these people better. So you have a lot of different routes for esophageal reconstruction. You can go into the anterior mediastinum, you can go into the posterior mediastinum, you can go in front of the colon, behind the colon, and then you can go subcutaneous. Raise your hand if you've ever seen a subcutaneous esophagus. Yeah, they're very rare. I did my first one last year, and it was really scary. So you can also, this just shows what it looks like if you go anticolic versus retrocolic. And just remember to close all of your mesenteric defects or they will get hernias. I've had one patient that had some bowel necrosis from a periconduit hernia as it was going anti-colic, and there was a little Peterson's defect that wasn't perfectly closed. So always remember to close those defects. If you go retrocolic, you have a little bit better length, but usually for supercharged, length is not an issue. And this is the subcutaneous patient. So this was a patient that was sent to me from Georgia, and he had an aortoesophageal fistula, and then had a problem where his stomach was destroyed. He had a small amount of stomach, but it wouldn't really reach very high. So we brought jejunum up and connected it to the stomach, and then connected the jejunostomy. But when we started to pull the conduit up, we realized that it wouldn't fit because he was so malnourished for so long and had lost so much weight that bridge over the edge of his costal margin was too tight. So I had to emergently, and I know Dr. Huang remembers this case, I had to emergently call in some of our plastic surgeons who did a reverse VRAM flap and created a skin bridge to cover the conduit so that we could get that conduit to be completely covered. And then a small skin graft, reverse VRAM, and then now this guy has this ridiculous looking, and he had a huge chest tattoo that looks crazy now. But he's eating again. This is free jejunum interposed in this position for a particular patient who had a gastric conduit that died. So it was the top third of the gastric conduit that died. And in this case, we were able to just reconstruct the cervical area. That's a great bridge for patients who have this particular situation or end up with a stricture that you can't dilate. And these are the 3 different ways that you can bring that jejunum up. Not common would we do the third, but typically what you would do is bring your jejunum off of your gastroepiploic, let it mature in the abdomen, and then when you go to unfurl it, if it's perfect, it unfurls and it reaches. But if it doesn't unfurl and reach, you can divide the mesentery and take this top part of the mesentery and plug it into the mammary, and the bottom part stays connected to your gastroepiploic. Or you can just bring it off gastroepiploic, or you can tie it in as a free jejunal graft to the mesentery. And this is detailed in that most recent publication in the Annals. And the arrows just point to your different your microanastomoses. So this is what it looks like when we're doing that T incision over here where it was diverted, and then the incision. And this is when we tried to pull the jejunum up so that you have a gastric conduit and you have jejunum and it's tied off of the gastroepiploic. So this is that limb of jejunum, and this is the jejunum coming off of the gastroepiploic, off of the stomach. And this is just the same as it's getting matured, and then when we tried to pull it up, didn't really quite reach. So we ended up having to divide it here, and then this part went in as a microanastomosis to the left internal mammary artery and vein, and we were able to get it to reach. But you can see once you divide the mesentery, this part becomes ischemic. So this is ultimately the reconstruction that we were able to do. And that's at the end. And you can see their swallow that actually looks quite good considering. So what about the free jejunum for just an isolated cervical esophageal tumor or an isolated cervical stricture? This is actually one of my good friends from college who had an esophageal cancer, and it was an isolated area right here. I met with Dr. Huang and we looked at different options for the residents. It's important to note that anytime you have an esophageal cancer that is 25 centimeters or proximal, you have to look in the airway and make sure you don't have erosion into the airway. So can you see this? When she had her bronchoscopy, it showed that there was erosion into her airway. And so she ended up dying from esophageal cancer. She could not have reconstruction, but sometimes you can have a laryngectomy and an esophagectomy and then reconstruction. And then Dr. Eddie Liu and Dr. Andrew Huang are experts at these complex laryngectomies with reconstruction. And this just shows that isolated resection for a patient that we did just a jejunal isolated interposition based off of the external jugular vein and transverse cervical artery in this case. But you can see trying to recreate, this is a colon coming up, and then they had an anastomotic stricture, so we just did a jejunum up at the top as a free jejunal graft to connect to the colon. This is starting to feel like those paper dolls where you cut and paste and you put them on. I thought maybe I was going to make a coloring book where you could put the conduit to replace the little section. So this is a patient who had an esophageal colonic stenosis, another one. They had, does anybody know what this is? All of you on this side of the room should be able to recognize, well, I drew it, but it looks like this on the x-ray. This is going to be the bane of our existence. I had a patient that I just had to do an esophagectomy on 5 days ago because of this. So this is an Axios stent. The Axios stent should not be left in for more than 3 weeks, probably should never be put in the first place. This eroded through an esophagus on a patient and went into the aorta. So I do not like those stents. So now we're on to pedicle jejunum, which is really what we were talking about for like the Marandino procedure last night. So a pedicle jejunum is just based off of the mammary, just based off of the superior mesenteric artery. So you can get a pedicle jejunum for a Roux-en-Y gastric bypass reconstruction, for a distal esophageal reconstruction, but it has to be very distal. Or if you have a gastric cancer, that's probably when you see it the most. If you have to do a gastrectomy, this is your preferred method of reconstruction. This is the Marandino procedure. It's a vagal sparing esophagectomy, and this is where you keep the right anterior and the right posterior and left anterior vagal nerves intact, and you do just a small jejunal interposition. This is not great for cancer because you want to do a good lymphadenectomy, but this is definitely something that you can do for patients who have a gastrointestinal stromal cell tumor or have a leiomyoma that was biopsied and there's mucosal disruption and you have to reconstruct. It's very difficult to perform, but can be a good solution. Now we have supercharged pedicle jejunum, and it's always a great option if you don't have a good gastric conduit. It doesn't require a formal bowel prep like a colon interposition does. It's usually free of intrinsic disease. You have similar diameter to the esophagus, so it does end up being a better tubularized reconstruction. And it does have intrinsic segmental peristalsis. So a colon interposition doesn't have peristalsis, but a jejunum does. And also the colon can sometimes undergo senescent lengthening. You know when you're flying in an airplane and you see the river that becomes like a snake and then it breaks off little lakes off on the side? Well, this is what the jejunum is like. Once you unfurl it, it tends to stay straight. But when you pull a colon interposition up, it becomes like that river and it gets senescent lengthening. And for kids that had a colon interposition pulled up, frequently we'll have to revise those when they become an adult. And we just have to do a segmental resection and a primary anastomosis to try to straighten those out. So the bowel length to mesentery ratio for small bowel is 3:1. So if you straighten the mesenteric out, you get about 3 times this length of bowel as mesentery. So that's why we have to divide it to try to get it to straighten out. So you can see once we divide the mesentery, the bowel becomes very straight and it can reach all the way up. So supercharged pedicle jejunums can always reach as high as you need them to go. That's one of the reasons why we like them for reconstruction. And this represents about 100 years of work. So Roux did the first small bowel reconstruction for esophageal replacement back in 1907. And the first supercharge was done in Russia by a surgeon named Dr. Andrusov. But back then it was so complicated, so much technology, so many steps, people found it overwhelming, and it didn't really become popular in the United States until we started doing it in larger academic institutions. And now we're doing this program where we're trying to disseminate the technology so patients don't have to travel across the United States to get these procedures done, and they can stay closer to home and closer to their home academic institutions. if you look at all the jejunal interpositions that have been published in large series, there's about, now we have about 500 in the United States that have been done, about a 1 to 11% mortality. Some series have as high of a 30% leak rate. I think right now our leak rate is below 10%, which is where you really want it to be. And then there are some cases that have about an 11% graft loss. I've only lost one graft, and that was from a patient that had an antithrombin 3 deficiency, and he clotted it off. And then we did another one, clotted that off, and that guy will be permanently diverted. That's the only one that we've given up on. So when we're doing supercharged pedicle jejunum, there are essentially 20 steps to doing this surgery. I know you did your homework, Dr. Andrade, and you have all 20 steps down. Excited to go through that today in that case. But we have a video that's available on YouTube if you want. It has, it's under my name, and it takes you through all 20 of these steps and shows video all along the way. This is a patient that had a prior sleeve gastric bypass with an esophageal cancer. So if you've had a sleeve gastric bypass, you cannot have a gastric conduit because they basically left only the lesser curve, and that cannot be used to interpose as a new reconstruction. So these are patients that we're getting referred to us increasingly, as so many patients in the United States have had sleeve, and then they end up with terrible reflux, and then they get cancer in the lower esophagus. This is a patient who had extensive tumor going 10 centimeters up into the esophagus and 6 centimeters down into the stomach. This patient had diversion and then got a delayed supercharge. So I would say in general, we're doing almost all of these in a delayed fashion, where we first divert, give them 6 months to recover, and then electively reconstruct them. So they're nutritionally replete. They've had 6 months of nivolumab therapy with esophageal cancer, and usually it's a bad cancer, so they still have residual cancer, so they're getting the adjuvant nivolumab therapy. This is a patient who had a Roux-en-Y gastric bypass, and we were able to just do a short jejunal interposition. And this is a patient who had a robotic, minimally invasive esophagectomy. I can say I've had maybe 25 destroyed conduits from robotic, minimally invasive esophagectomy. And I think that that's because of the unintended lateral thermal spread from the robot, where they end up with a conduit to tracheal fistula. So I know the Memorial Sloan Kettering group, Natsu Sarkaria, presented their early series of robotic esophagectomies, where they had 3 in their early series, 3 airway injuries. So this is a patient from Colorado. He had a fistula to the right mainstem bronchus, a fistula to the left mainstem bronchus, and then had a little bit of tracheomalacia from all of the injury. And we brought the stomach back down into the abdomen. We did a right thoracotomy and fixed the right mainstem with an intercostal muscle flap. We did a left thoracotomy and fixed the left mainstem injury, but we couldn't quite reach it, so we had to do a median sternotomy and fix this area. And both times we had to put him on ECMO to reconstruct the airway. Once the airway is reconstructed, we sent him home, diverted, 6 months, wait, then come back and get a supercharge. And today he's eating fajitas. This is just an example of the video. If you want, it's one of our earlier series from when I was at Mayo. And this is the QR code if you want the video. Happy to share that. Also, when you do a program like this, it's important to build a pathway and a checklist. And this isn't meant for you to be able to read this whole slide, but just to take you through. We made a list of everything that we needed to do. So every patient gets everything on this list, whether it's nutritional optimization or psychologic counseling or frailty assessment. We found that if we skipped a step, we would end up with problems. And so we built a standardized pathway for all of these patients so that they get the best care possible all along the way. And this is just some of the modifications. Every time we had a complication, we would do a root cause analysis. We would make a list of all the problems that happened and what could we do to try to make it better? What could we do to try to never have that happen again? And so we started using a Cook Schwartz instead of exteriorizing the piece of bowel. We started putting a little bowel window just to be able to see it rather than just doing a Doppler probe. We started doing the esophageal anastomosis before we did the micro. Because one time we did it after and we disrupted the micro while we were trying to do the bowel anastomosis. And sometimes we did hand sewn. Now we're doing stapler because it's much faster and you have a lower stricture rate. And then we almost always go anticolic and retrosternal. So as time went by, we started standardizing to do it the same way every time, unless there's a reason that precludes doing it that way. And we were able to have 0% 90-day mortality in all series that I've ever published. This is just showing the bowel translumination. As we start to look at the arcades, you start to try to pick which arcade are you going to use. And this just shows the superior mesenteric artery and vein. That first arcade supplies the ligament of Treitz. That needs to be preserved. The second arcade is the one that usually goes to the mammary, and that's the one that we take. And this is showing the arcade as it unfurls in that similar graphic that was shown earlier. And this just shows the complete unfurling. So you can divide the mesentery between the second and third arcade, between the third and fourth arcade, using the fourth still connected to the superior mesenteric artery, or also using the fourth as an additional pedicle to give you longer length. So this one gives you the longest pedicle that looks a little bit like this, that goes all the way up to the earlobe. And this is that unfurling again, where you can see we're starting to stretch the bowel out. You can see all the different arcades in the pedicle that will eventually be connected to the mammary. And this is that area. This is actually published in Annals, but this is the whole jejunum as it's coming up. This is divided all the way up to the bowel wall. This is that second pedicle that's going to the superior mesenteric artery, the second branch that goes to the mammary artery and vein. And then this is that bridging pedicle, third branch. And then the fourth is kept connected to the superior mesenteric artery and vein. And this is what it looks like when you start to bring it up. Again, you can see where the mesentery has been completely divided, the bowel's straight. All of this is supplied by the SMA, SMV, and this will be microvascular anastomosis. You can see the little anvil coming out of the esophagus right before. This is just another picture of what it looks like as you unfurl, and another picture of what it looks like. So they all start to look the same, and you start to be able to recognize the patterns and pick each thing out. And this is Dr. Huang's work when you're preparing the mammary. So my job at the beginning of the case is usually to get the esophagus diverted. We'll work hard to try to get the head of the manubrium, a quarter of the manubrium out, the head of the first rib, the head of the second rib, sometimes if you need extra length, but usually we can just take out the first rib and the proximal end of the clavicle. So I'm going to hit both of these at the same time. So over here you can see usually a 3.5 millimeter coupler is what's used to connect the mammary vein to the external jugular vein to the mesenteric vein. Raise your hand if you've seen a venous coupler before. Oh my gosh, we need this for bowel. It's so great. So you basically evert the vein and stretch it out, and then you put the other vein on here and evert it, and then you close it, and it's connected. It's absolutely beautiful. I could watch this all day. And then this is the arterial anastomosis that's created with a 9-0 nylon or a 10-0 nylon. Raise your hand if you've ever sewn with a 9-0 nylon. All the microsurgeons are raising their hands. Yes. So this is what that arterial anastomosis looks like. This is what the venous anastomosis. Okay, here it is. It's closing. And you'll see once it opens back up. And these are little Acklin clamps. And those get released after the anastomosis goes. And there it is. It's beautiful. And then they'll take the clamp off, and you can see the blood flow. So again, we learned from the series at Methodist, And then we took it to Mayo Clinic. When we started doing supercharged pedicle jejunums at Mayo Clinic, it's very important to note that, and I hear this from cardiac surgeons all the time, they try to shame you and they're like, why don't you do your own micro? Because they do an arterial anastomosis to the heart. And I say, because my microsurgeons have done 5, 10, 400 cases, 5 years of experience. It's amazing what they can do under the microscope. So I think I would never try to do that part of the surgery. So it's important that we emphasize we will only train teams where you have a thoracic surgeon partnered with a microsurgeon, and both people have excellent skills, excellent experience. This isn't the type of surgery that you train someone fresh out to learn how to do. You have to learn how to do the basics of esophagectomy, reconstruction, troubleshooting, and then a lot of mentorship. So this is after one of our cases where we have a small little window to visualize the area and a Cook-Schwartz Doppler coming out for monitoring. And again, from the 10 years that I was at Mayo, these are all the standardizations that we created to take care of problems that we encountered, whether it was bleeding because of the edge of the sternum rubbing up against the artery and causing erosion. Now we take the periosteum and we fold it over to cover it so there's no raw sternal edge. Or all the different complications. These are all complications that we had. And then these are all the ways that we tried to fix the complications. For monitoring, when I came out of MD Anderson, this is what all of our patients looked like. There was a little piece of bowel that looked like a leech that was like squiggling around outside the patient's chest. We would wrap it up into the pod and then we'd put drains in. And then we'd amputate it right before they went home. We don't really need to do that now. We have these Cook-Schwartz Dopplers, but we're sometimes a little cheap nowadays, and we just put one on the artery or one on the vein. If one goes down, the other one's going down. It's probably helpful to just have it on one. And this just shows, again, that area where you look at the left internal mammary artery and vein, a quarter of the manubrium gone, the head of the clavicle out, and the head of the first rib out to give you exposure of that mammary artery. These are our outcomes. I developed a patient-reported outcomes longitudinal survey that turned into an app, and we've published the before inside of a year versus outside of a year outcomes in these patients as it relates to pain, dysphagia, reflux, dumping, hypoglycemic dumping, and systemic or gastrointestinal dumping. And these patients actually do quite well even when they're a year out. I won't talk so much on colon interposition because I think it's difficult to go through in detail, but I think most of our patients, if we can do jejunum, we do. This is a patient who had a gastrectomy for cancer and then had an esophagojejunal anastomotic dehiscence, had a stent that was placed in, and then the stent eroded into the colon, and so then they stented the colon. So this was a disaster. So we had to take out part of the colon, we had to take out all this and divert her and reconstruct her with the supercharge. But she'd already had a roux, so the supercharge was out. So we ended up using a piece of her colon, but she'd already had her colon stented, and this part had to be resected. So we actually did a free colon interposition. And then there's a very public patient in town that we've operated on and reconstructed, and she's been on the news, so I will ask you to go to her store, which I think is lovely. She is in Apple Valley, Minnesota. She has a store called Sweet Treasures. A lot of really good news stories about her. She had a gastric cancer as well, and she actually has gone through some of these surgeries. Really amazing people. So this is another patient that had a free colon interposition going from esophagus down. And I think King Kessler has really done the most work of all of us with supercharged colon interpositions. And he's at Indianapolis. I don't think he's operating anymore, but for a while he did these. And these are just the different parts of the colon that you can use to reconstruct: right, left, transverse, all based off of that marginal artery. And this is a picture from his publication of the supercharged colon interposition. And then there's the myocutaneous flap. And I was trying to get Andrew to come up and talk, but I think he's being very shy today. So this is a woman who actually became my scrub nurse in the operating room. She had a stricture from an injury, and we reconstructed her cervical esophageal stricture with a free forearm. We had 2 pedicles here. One pedicle was on the inside of her esophagus, and the other pedicle was out here with this little proline stitch where we knew to put the Doppler so that we could check the viability of what was on the inside. And then a year later, we basically took this skin paddle out and revised her scar and made it look nicer. But there's nothing like having a scrub nurse who's been through all these complex surgeries to be able to hold your patient's hand as they go to sleep. And then we also have, and this is just coming out in the Annals of Thoracic Surgery. This is the worst disaster that I ever cared for. This is a patient who had a laryngectomy and a TE puncture for phonation, and then got a TE fistula from the TE puncture, and then had esophagectomy with diversion because somebody stented him and he got an esophago aortic fistula. He had a Commerle's diverticulum and a right-sided aortic arch. We diverted him, and then we reconstructed him with a supercharge, but because he'd had 70 gray of radiation to his neck, the anastomosis dehisced, and so we did a right myocutaneous latissimus flap and brought it all the way up. And when we scoped him, he had a hairy esophagus because we made a skin tube from that right latissimus. But the blood supply came, that's the inside of his esophagus. And that's the jejunum. And that's what his neck looked like. But this is what we call the BYOB flap, which does not mean bring your own beer. It means bring your own blood supply. So this might be why when you're training for thoracic, you need to train on the cardiac service. For those of you that do aortic surgery, we're very good at doing a little axillary artery graft because that's how you do antegrade cerebral perfusion for circulatory arrest. I could do that procedure in my sleep. So we took a saphenous vein, we tied it off the axillary artery and vein as an AV loop, and then we let it mature like an AV graft for a dialysis patient. And then 2 weeks later, we divided the AV loop. So we had arterial inflow, venous outflow, and this is just a schematicized area of that skin conduit because it actually had muscle around it. And this is what it looked like 3D. So here's your trachea, here's the esophagus, the hairy esophagus, here's the micro part, and then here's that fat around the tubularized skin that used to be the latissimus. And then here's that muscle that came around it to really rebuild the back of that trachea with. That was a horrible case. I never want to do it again. And this is an ALT thigh flap. That's another option. The microsurgeons do all the work. We just do an anastomosis and that's it. And then there's an option for synthetic grafts, which are not ready for prime time, but I've killed a lot of pigs trying to figure out how to do that. We worked in the lab for many years trying to rebuild these biosynthetic grafts using exosomes to promote healing, using novel grafts, using scaffolds to try to grow new cellularized reconstruction, and then sometimes stenting them so that while they're healing, the saliva is diverted so it doesn't end up getting infected. Those are not ready for prime time. And we don't really have time to go into special circumstances, but I have each of these as a separate video on a YouTube channel. This is if you don't have a long enough esophageal diversion, using a PEC skin tube to recreate a new esophagus so that they have an ostomy that fits, that functions well. This is plicating your conduit to try to make it more narrow. This is a patient that Andrew and I did reconstruction on. We'll be revising her next month. When she swallows, she has too much jejunum up here. So you can see this redundant jejunum. And sometimes I err on giving them redundant jejunum because I don't want the anastomosis to be too tight. It's always, think of it like a wedding dress. You can always take it in, but you can't ever let it out. So we always try to tailor those over time. And this is just the internal plication. I came up with this idea a long time ago because I didn't understand why end-stage achalasia patients get an esophagectomy, why do we take a bag of esophagus and replace it with a bag of stomach? Why don't we just try to make the esophagus that they have shaped a little bit better so that it works? And so this is just going in, and maybe I'll try to advance through this so you can see. We're using the Apollo endoluminal suturing device, and we're plicating the inside to make it a skin, a thinner tube to swallow through. But we can do that with our conduits as well. And this is a picture of what it looks like when we've done some internal plication before. This patient had a sump from a colon interposition, and we internally plicated using that Pope technique and straightened it out so that they could swallow again. And this is a patient that had external plication. So she had, as a baby, she had a TE fistula, and they pulled her whole stomach up and reconstructed, and she had this sump formation. So we externally plicated, and you can see the sump is gone here. So sometimes these things need a little bit of tweaking over time to make them better. And we've treated patients with tracheoesophageal fistulas. We typically use an intercostal muscle flap to buttress and repair that area and then reconstruct in a delayed fashion. Don't have time to go through tracheoesophageal fistulas or esophagoatrial fistulas or esophagoaortic fistulas, but we have a huge series of each of those. This is just a terrible tracheoesophageal fistula with a common channel here. This is esophagoconduit fistula, where you can see that left main stem fistula going to the conduit. And then this is using a PEC flap to rebuild the trachea with a small skin paddle that we were able to bring down because the patient had already burned other options. And this is that tracheal defect that was reconstructed. This is just showing that tracheal reconstruction for a patient who had a conduit problem. This patient had a robotic esophagectomy, and they burned a hole in the airway, and so we used intercostal muscle to come up to the trachea to reconstruct. And then endobronchial fistulas. We've seen a lot of disasters. Sometimes the fistula is so long you can't use one intercostal muscle flap, and so you have to use two. And that's usually somebody who will be on ECMO for a week recovering. And this is the esophagoatrial fistula after ablation for AFib. And esophagoaortic fistulas, we usually stent those. So here's just a bird's eye view of the process. When I meet a patient, I draw out, here's what you need, here's the testing, here's what we're gonna do, here's your treatment. If it's esophageal cancer, here's the treatment they'll get, and then here's your survivorship, and then at the bottom, hopefully cure at 5 years. But I draw everything out so they can see what that journey is gonna look like all along the way. And this is, Dr. Andrade remembers this club. This is called the Esophagus Club. A long time ago, we used to meet and present difficult cases to each other. We're bringing that back at the Southern Thoracic Surgical Association. And you can see the esophagus is tied into a knot. This is basically like the adult surgeon esophageal club support group. And this is just a picture of the app that we developed to follow patients longitudinally for their patient-reported outcomes. And the survivorship clinic that we built around that. So just in conclusion, long segment esophageal reconstruction can be accomplished with a variety of different techniques. Always use your stomach when you can, and meticulous attention to detail with care pathways, checklists, root cause analysis, and care algorithms. Jejunum is best for long segment replacement. Always delay your reconstruction. Get them nutritionally replete, prehab, reconditioning, and just remember complications happen. Try to plan for all of those along the way and follow your patients longitudinally. So just thanking my teams of people throughout the years, and especially my new partner, Dr. Huang. It's great to work with you. And Eddie does a lot of the proximal upper esophageal diversion and reconstruction work, especially laryngectomy work. And they together have a partner, Julina Onkasawan, who helps to renervate the recurrent laryngeal nerve if we happen to knock that out, which is nice. And then the former partners that I've had throughout the years. That's it. Thanks. I think we have time for questions.
Thank you, Dr. Blackmon, for a world-class lecture. I think I'd like to ask a couple questions, and then we'll leave it open. So our experience with retrosternal reconstructions is they leak a lot, particularly with stomach. And I don't know if it's just pulling hard. My suspicion is, and what happened to this patient, Julie, from today, is that we have, since most of our cases are hiatal hernias, we have a lot of esophagus when we divert them. And my suspicion is because it's so long, it's ischemic, and that maybe that's why our leak rate is high. Because with stomach, it's about 40%. With jejunum, when we just do non-supercharged, it reaches the angle of Lewis. I could see that in your picture too. That's kind of where it gets ischemic. It's less, like 20%, but it's still way higher than we'd like. So I wonder what your thoughts are about too long of an esophageal remnant. And then because of that, we leave our wounds open now. We just pack them, because then you can see the leak. Because even if the leak festers for 12 hours, by the time it starts causing a wound infection, it's already too long. It's been sitting in that soup. So the sooner we see it, we can manage it, and then most of those kind of resolve on their own. Today's case, I was wondering if we should just leave it open so we can see the cartilage in the MS.
Samir Mardini liked to do that. He liked to have that window, and I feel like we got our leak rate down because Andrew would let me close that window. If that window's open, a lot of junk is falling into the wound. And anytime you get that wound contaminated and it gets dirty, I think you're doubling your leak rate. The number one predictor of an infection at the time of surgery is an infection somewhere else. And anytime you make that wound dirty, it's more likely to leak. The other lesson that we learned is when I was working with Pierre Chevre, who had trained at MD Anderson and then came over to Methodist, we used to fight like an old married couple over where to place the drains. We usually put a drain to the right and a drain to the left. And Pierre always wanted to put the drain right on top of the anastomosis. And I know that Sean Groth, who's done some of these, and I and Taylor Ripley, all three of us believe that that drain cannot be on top of your anastomosis, that it has to be like 3 centimeters away and dependent to the anastomosis, so that if whatever's coming out as a leak is falling down, it's going to be caught with that drain. And I would say we've cut the leak rate in half by getting the drain away from the anastomosis, and then cut it down even more by not leaving it wide open and allowing saliva and junk and things to fall in. I don't know that that's perfectly scientific, because I've only done about 100 of these and we've changed quite a few things along the way. But what I can say is now we do it the same way every time, all the time. And if we change one thing, then you can maybe have enough cases to measure, is it making a difference if you're just changing one thing. But if you're changing everything every time, you don't really know if it's making a difference.
What do you think about the too long of an esophageal remnant? Because the blood flow of the esophagus is segmental. So the more you skeletonize it.
Yeah.
So usually when we have a long esophagus, the distal 2 centimeters we know are going to go away. They have stricture. But I wonder if that has contributed to our leak rate.
Yeah, I think definitely a long devascularized esophagus will lead to a leak. I've seen it when I do a diversion. Sometimes I don't create a pathway that's wide open, so the tip of the esophagus turns black and necrotic. And then that always ends up cleaning up over time, but patients are they think you don't know what you're doing if the tip of their diversion looks black and necrotic and it smells bad. There's also a protocol that we instituted for helping patients to maintain their esophageal diversion. I have them drink they get those little baby Dixie cups and drink a cup of Listerine 3 times a day, and they swallow it. So it goes through and it cleans the bag and it maintains the bag. And then we actually teach them how to go eat. And then are you like the one that ends up talking to the patients about the diversion? So it makes the bag not smell. It makes the conduit much cleaner. And it's not for when they're reconstructed, because drinking Listerine is really bad for you. Only when you're diverted. Only when you're diverted can you do that. But it does keep things, kind of clean and not so smelly and better. And then it also helps to clean the bag so they don't have to use so many bags.
Any questions from Maddie?
Thank you for that amazing talk, and I do think you're still a great artist.
Yes.
My question is, I want to reiterate the point you made about the longitudinal follow-up. I do think that's so important and probably so much overlooked. My question is, what sort of resources do you have, or how do you maintain that? Do you have a database? Do you have how are you able to maintain it?
I've always maintained a prospective database, monitoring all of the outcomes of these patients. But in addition to that, I was a patient a long time ago when I was going through IVF therapy, trying to have kids, and I could never get in touch with my doctor, and I had some complications, and it was because I couldn't get in touch with the doctor that those were magnified. And so I swore to myself that I would always give my patients my cell number. And so I've always done that for my whole career. I give my cell number to every single patient. And I don't think they abuse it. I've only had like a couple of times, although my son's in the audience, he goes here, and he's used to like every second of the day I'm getting called. But I think it's worth it to be able to answer questions, treat problems. If I have a patient that I did a foregut surgery on them, and 5 years later they have a complication, they're much more likely to call you if they have your cell number and say, I can't swallow, I have Borchards triad, what do I do? Of course, they're not going to say that, but you would basically be able to help them much better. So I think that, to me, has been the most fulfilling part of my career, and it helps to mitigate burnout, staying connected to those people over time.
Other questions? Amit?
So that was great. Thank you. But you just brought up IVF. I know that we do have a lot of women.
We were talking about this.
You want to talk about
yes, it? Thank you for the reminder. So we were talking about this last night at dinner. So anybody that's in this field knows that it's an arduous journey, and it's a long journey. And if you want to go into cardiothoracic surgery, God bless you. It is a great specialty. There's nothing as good. I saw somebody like wrinkling up their nose. It's actually beautiful. And people ask me about work-life balance. If what you do every day energizes you and brings you great joy, you're not trying to balance it with life. It is the part of your life that brings you joy just as much as going home and being with your kids bring you joy. So you're not trying to balance it. If you're making widgets in a factory, then you need work-life balance. But if your work is also your life, then you're not trying to balance it so much. That's all I'm going to say about that. But also, men who have women that are in a high-stakes career, or women who are in a career like this, you should bank your eggs and preserve your fertility options. It's almost every woman that's ever trained with me. I said that to them, and they looked at me like I was crazy, and they came back 10 years later and said, thank you so much. And be more vocal about needing to take time to do that. I think you're a lot more protected by rules these days where you can take time off to do that. It's difficult. It's hard to sometimes schedule because you don't know when that timing will be. But I think you have a very supportive environment, and you have attendings that care so much that they ask me to announce it to you. So they obviously do care. It's just, we've done some research in this area. We have, in our career, we have a little bit higher miscarriage rate, a little bit higher IVF rate. And so, do everything you can if you have a desire to have a family to protect that by baking your eggs.
And there you go.
Kind of an odd way to end.
So we're not all thoracic surgeons in the room, but we all have the equivalent of a gastric interposition in our practice, right? Something that we do pretty frequently to manage a complication or the primary management of a problem, and we can do it well. We do it a lot. And then I think we all also have aspects of our practice that are only used in the cases of like a complication or a very complex patient that comes to us. We may do them, but we don't do them all the time. What's your recommendation to surgeons as far as managing the complexities around those types of cases? And like, we know we can do them, we know we're the right person to do them, but we don't do them all the time. For junior faculty, it causes a lot of anxiety, and it's like, well, I know I can do this, but I haven't done it for a while. What's your recommendation to help us prepare for those cases, or I guess similar to the patient side of things, making a list or a database or a, for yourself to kind of go back to and reference when you do have to do these more complex cases that are by nature higher stake?
Yeah, I mean, the easiest thing I would say is you need a support group. I mean, I have a support group. I've done this for 20 years. I mean, I trained to do this at Anderson and then hit the door running. But Daniela Milena, Linda Martin, Mara Antonoff, and probably 3 or 4 other women, you should see our little chats. They're ridiculous. It's like, what kind of underwear are you ordering for your daughter? And what kind of anastomosis would you do in this situation? And what are you doing here? Like, the conversations are all over the place. It's really helpful to have a group that you can share transparent failures with and talk about those challenges and troubleshoot. And like yesterday, I had somebody call me with a disaster that they're in the process of that's landing in our hospital right now that I'm going to have to do a supercharge on. And, talking through that, it's very likely that whatever you're going through, if you have the right group, that they've seen it before. And it also helps to drop the stress level. And then you learn from our mistakes. So my uncle is a general surgeon. He was back from the day where they did vascular, a little bit of thoracic, all of the gamut. And he said a good surgeon learns from their own mistakes, but a better surgeon learns from everyone else's. So the more transparent we are about our failures, what we tried, what worked, what didn't work. I mean, I'm just really grateful that publication about the hernia mesh got that update at 5 years so that people stopped putting mesh in. I think being transparent about failures is more helpful than being transparent about success. And I don't really like videos where everything goes perfect. I like seeing video where somebody struggles. I think I learn more. Or where you had a bad outcome and then what you did to treat the bad outcome. I think that's where we start to really learn. We've started a new thing at Baylor called Movie Night, but it happens in the morning, so I don't know what to call it, Movie Night, but it's where we just play a video from a case and we talk through the case. And usually it's where I did something wrong, like where I cracked the pulmonary artery because I was being too aggressive, or where I did something that I shouldn't have done. And, playing back that video and showing the residents the anatomy when you're not in the heat in the middle of surgery is just a great way to teach. And so maybe record all your cases and play it back and have people, critique them. It's very humbling.
If I may just add, something I learned with time is for complex cases, we always double scrub. So when we do all our esophagectomies, we double scrub. So there's always one person is the main surgeon, and I'm always the backup surgeon, or if I'm the main surgeon, one of my partners is because then they help with the critical steps of the operation. They don't have to be there all the time. But that alone, just knowing that my partner's there, your stress levels have gone way, way, way down. And I think it's something that we don't talk about enough. It's all about this, I can do it all. And there's no need for that. And it's not, what would you want for yourself or your loved one? you want that's what goes to the comment about the recurrent laryngeal nerve. You want the best person to do it. So if you need help, and that's a other important thing that Dr. Blackmon highlighted is multidisciplinary teams. There's no reason why she would have to learn something if the ENT surgeon, Dr. Huang, has done it 400 times. Why does she have to do it 50 times? And then, it's going to be a problem. Why put the patient through that? But I think the most important thing is always have a partner, always talk to your partners, talk to your colleagues, and be aware of fatigue. I have observed over time, I think it'd be hard to measure. The more tired I am, the more complications I have, then I know it's time for a break. I take a break, and then things get better. But I haven't seen anything published. I think it'd be very hard to measure, but I know for myself that that's the case. Okay, I think we have to finish. Right? Thank you, everyone. It's been great.